Hello, all. Good afternoon. My name is Dr. Vel Murugan from Sri Ramachandra Institute of Higher Education and Research, doing my first year post-graduation in orthopedics. I'm here to present my poster on percutaneous posterior stabilization with vertebroplasty in painful thoracolumbospinal metastatic disease. It's a retrospective study, and I hereby thank to my authors and my professors, Dr. Anil Chanda, Dr. Vignesh Jaybalan, Dr. Karthik Kailash, and Dr. Sid Sabesian. And the abstract is to do a retrospective evaluation of the clinical outcome of the patients with spinal metastasis treated with minimally invasive posterior spinal stabilization and vertebroplasty. We took and we analyzed 22 patients with biopsy proven metastatic thoracolumbar spinal lesion treated with percutaneous posterior stabilization with the pedicle screws and vertebroplasty operated in Ramchandra Medical College from June 2006 to May 2012. We took only neurologically intact patients with Tokuhashi score of 9 or spine instability neoplastic score of more than 6 were included. Average age was 61 years, and we followed them around, 61 among them. 22 patients we took for there were 14 males and 8 females. Clinical outcome using pre and post-operative visual analog scale, intraoperative blood loss, duration of the surgery, time taken to mobilize the patients after surgery, and length of the hospital stay were analyzed. The average visual analog score decreased from 9.2 post preoperative to 4.1 immediate postoperative and 2.2 in 3 months period time. And the Karnofsky score improved from 45% to 70% postoperatively. Average blood loss was 80 ml and surgery was lasted for 85 minutes. 15 patients were mobilized on the second postoperative, with most patients discharged on the fourth day itself. Hereby, as a general introduction, spinal metastasis is the most common metastasis, mostly in the thoracolumbar region and thoracic region, around 70% in most of the cancer. And the patients, and in these patients, so far, doctors were using percutaneous vertebroplasty was used in treating the vertebral hemangiomas, was later extended to the osteoporotic and metastatic compression fractures. Many studies evaluated the efficacy of vertebroplasty in managing painful thoracolumbar spinal metastasis. We asked whether addition of posterior instrumentation to vertebroplasty of the involved vertebra improved clinical outcome in these patients. To our knowledge, no studies had been published previously in this regard. The materials and methods we performed retrospective analysis in 22 patients, which is already I noted, I've said like from 2006 to 2022. I'm sorry, 2006 to May 2012. In all patients included CT guided biopsy. If the involved vertebra showed evidence of metastasis, the diagnosis of primary tumors was also established. All patients had painful single or contiguous two-level thoracic or lumbar vertebra metastatic fracture and not responding to conservative therapy. All patients included were neurologically intact as per Frankel's grade D and D with revised Tokuhashi score, which includes Karnofsky performance scale and Frankel's grades of more than 8. The spinal instability neoplastic score was greater than 6 in all the patients. Patients with primary malignancy of bone, such as multiple myeloma, were excluded. Contraindications included more than 2 levels involvement and non-contiguous involvement, failing to localize symptomatic level, involvement above T6 vertebra, neurological involvement, frontal ABC, significant neural compression with the disruption of posterior vertebral cortex on MRI, pain that was significantly radicular in nature, local skin infections, and patients with severe medical comorbidities were excluded in the study. Around total of 22 patients, males were 14, females were 18. 9 patients had bronchogenic carcinoma, all males male. 6 patients had breast carcinomas, GA malignancy were 5, and thyroid were 2. Among that, 1 male, 1 female. Levels involved, single level patients had 14 patients, 2 level were 88 patients. And the most common level is T12, and second most common is L1. After informed consent, vertebroplasty was performed in the operating room under CM guidance. In prone position, 13-gauge needle, osteocyte bone biopsy needle was introduced to the posterior aspect of the pedicle along with supralateral cortex and directed anteriorly and medially and caudally to reach the anterior third of the vertebra and near the midline in sagittal plane. 40 milligram polymethyl methacrylate cement was mixed with 10 ml liquid monomer and was injected into the vertebral body with the help of multiple 1 ml syringe till the anterior two-thirds of the body was filled. Leakage of the cement was confirmed with fluoroscopy. Average amount of 5 ml was used. Pedicles were cannulated using Jamshidi needle. Guide were inserted in the pedicle tract and cannulated pedicle screws were inserted percutaneously, followed by rod insertion. All the patients underwent short segment instrumentation. Duration of surgery, amount of blood loss, intraoperative complications were noted for each case. Length of the hospital stay, time taken to mobilize the surgery were also analyzed. Patients were followed on 1 month, 3 months, 6 months, and 1 year time period. Visual analog score scale, Karnofsky performance index were analyzed. As per the results, were average follow-up for 4.5 minutes. 1 month, all the patients were available. At 3 months, 18 patients were available. 6 months, 12 patients were available. At 1 year, 10 patients, and one died within a month due to the other causes. Operator level, most commonly in the T9 to L3, most in the assay T9 and then the L1. Visual analog scale, which was the pre-operatively, which was 8.8, was improved drastically to 2.2 in the 3 months post-operative time period, and 4.4 in the immediate post-operative period. And the Karnofsky's performance index improved from 45% to 70% in the post-operative period. 18 patients had immediate pain relief. Average blood loss for 80 ml and average timing was 85 minutes. And the results from our study, as per the discussion, were even though percutaneous cement augmentation has been used successfully in managing patients with metastatic spinal disease successfully, the rate of complication of this procedure is higher in these patients compared to osteoporotic compression fractures. There is a risk of symptomatic leakage of cement into the spinal canal. We didn't analyze with the CT about the cement extravasation, but still, Weil et al. And Cotten et al. Were the earliest to report the use of percutaneous vertebroplasty in the management of spinal metastasis and myeloma, the largest in North American series reporting augmentation of cement for metastatic spinal disease and myeloma is that by Forney et al. A total of 97 procedures were performed in 56 patients. Patients noted marked or complete relief of pain after 49 procedures. There are various minimally invasive techniques, including vertebroplasty, endoscopic assisted surgery, and many open surgery have been introduced, shown to have acceptable clinical outcomes in the metastatic spinal disease. But vertebroplasty alone seldom addresses instability due to the metastatic fractures. Co et al. And Acosta et al. Concluded that kyphoplasty and vertebroplasty supplementation may improve the long-term integrity of short-segment pedicle screw constructs and allow improved rates of fusion and better clinical outcomes in the patients with traumatic thoracolumbar burst fractures. Park et al. And in their retrospective single-center study used percutaneous pedicle screw stabilization to treat unstable metastatic spinal disease. They concluded that minimally invasive treatment using percutaneous pedicle screw fixation with adjuvant treatment is a good alternative treatment option for potentially instability of the thoracolumbar and lumbar spinal metastasis. Combining the above principles, we use short segment percutaneous pedicle screw fixation along with the cement augmentation of the involved vertebra in managing spinal metastasis. In our study, patients' outcomes were similar to those in the literature. Complete pain reliefs or improvement occurred 81% of the patients after index procedure. As I mentioned, mean VAS has improved to 2.23 in a 3 months of period. To conclude, percutaneous posterior stabilization with pedicle screws and vertebroplasty provides good pain relief and short-term clinical improvement in patients with thoracolumbar spinal metastasis with spinal instability. Patient had decreased intraoperative and postoperative morbidity, shorter hospital stay, and early return to the activity in our series. Randomized control trials were needed with a large number of sample, large time period of follow-up is needed, and further analyze risk and benefits to this procedure. Thank you.